All, this is Dr. Mobeen Sayed from DrBeen.com. Welcome to one more show. Today we have moved the open forum because it is Christmas on Friday. We have moved it to today, and with your permission, I am going to take off on Christmas Eve and Christmas and on Saturday as well. So three offs in one string. I think this is the first time during this year that I'm going to be taking 3 off. So thank you very much for letting me have these 3 vacations. So we'll see each other after this on Monday. But if there is anything that is compelling, that is pressing, I am home, and I would come back online if needed. So with this, please make sure that during this time, one, you stay relaxed, you sleep well, take your supplements, and keep your body, your immune system optimized. And keep taking care of yourself during the Christmas as well. Some social distancing care. There is nothing bad in caring for yourself and caring for others. It is just it is a civil thing to do. So please keep yourself protected and safe. Vaccines are here. About 1 million people have been vaccinated in the US. I think it is slightly slow pace. I would have expected much more than that, but still, it is a good news. The second good news is that US has now struck a deal with Pfizer to give another 100 million doses, I think by June. There may be slight delay, but by June. And that means now 400 million doses, 200 million from Moderna and 200 million from Pfizer have been allocated for US. So somebody had made a comment that the dose numbers that I talk about are for the world. These are allocated for the US, and they are supposed to be here by June. So still a long time, and I would request to stay vigilant, keep your guard up, and keep protecting yourself during this time. And whoever wants to be vaccinated, I think will be vaccinated soon. So with this, let's start our discussion. I am enjoying the coffees that I'm getting. I'm getting so many coffees. So thank you to everyone who has been buying me coffees. So thank you. I'm going to spend some of the coffee money on coffees in the coming days as well. So thank you very much. Okay, so with this, let's start a discussion. We'll make an open forum today. And so let's look at some of the discussion. So this was funny for me, that show more replies. And if you see here, this is the thread. Then it says down here, Facebook, show additional replies, including those that may contain offensive content. So if I say show on that, here is the something in here is offensive content. And before my answer, it was still locking it down. So very, to me, they are not offensive things. I do not know how Facebook finds them to be offensive. So here, Mariesta Dersh says, yes, please take off and enjoy your family and have a Merry Christmas. If you get lonely, we can rewatch an older video. If we get lonely, we can rewatch an older video or go to your site and watch anything else if you've subscribed. So thank you very much. And Merry Christmas to you as well. Happy holidays, and stay happy and relax. It is important to take rest and relax during this time. This is very important for COVID as well. Then Mariesta Dersh says, question, is it true if you got flu vaccine, your test would show positive even if you don't have COVID? So I have a site here which shows that getting a flu shot does not affect your COVID-19 test result. And then just to explain it, what happens is that when you have a flu shot is going to cause, just like other vaccines, like COVID vaccines, what it will do is it will allow some cell to pick up that vaccine and then show to the immune system the antigen. And then the natural killer cells will be binding to it. Sorry, not natural killer, naive T cell. And then it is possible that we'll have some T helper 2 pathway and B cells, which is called humoral response, and antibodies will be formed. Or it is possible that T helper 1, I'm just putting down the normal immune mechanism, B cell, and then cytotoxic T cells will be created. With this, it is also possible that the innate arm, that includes the natural killer cells, macrophages, dendritic cells, that would react to the vaccine and either try to take it up and clear it or present it. So this cell over here can be a common cell, or this can be an antigen presenting cell, for example, dendritic cell or macrophage. So when this happens for flu, after the flu shot, this has nothing to do with the COVID RNA present in our throat. These are antibodies, for example, produced or trained cytotoxic T cells or trained innate arm cells. So they will not either have the RNA of the coronavirus or will have reactivity in a way that these cells can appear as, or the particles of these cells can appear as the test. I'm just reaching to try to make sure that can there be any possibility that this flu shot would then end up causing a positive for SARS-CoV-2. So that will not happen. Then Sapien Society here for betterment of humanity. Question, why can't a world-renowned medical lecturer like yourself just pick up the phone and call the top dog at CDC, NIH, NHS and ask them relevant questions? Do they answer to no one? They're employed by the people. So unfortunately, that is the situation. They respond to no one other than their own selves or their bosses. I had actually tried to reach out to Fauci's department and try to talk with him or somebody in his team, and they simply declined, saying they're too busy to talk with me. This is a similar situation that I had reached out to some other YouTubers as well who are serving at this time, and they had declined. So I think it is just, this is just how it is. So be it, but thank you very much for this comment. Ideally, it should be that people come together and they work together to find a solution. Outside the box, are you concerned at all about the already large number of adverse reactions to the vaccine when the worst of the reaction seems to come after the second vaccine? So, of course, there is a concern. However, the couple of things that are interesting and important to keep in mind are, number one, if you look at this from CDC, without giving them, I'm not a fan of them. I think everybody knows now, at least not during this pandemic. I used to have more respect for them before. They are saying that whenever the vaccination is occurring, there should be all the facilities available to take care of the reactions. The reaction at this time, the reaction rate is 1 in a million. And of course, in the US, we actually saw more than 1 in this 1 million doses. Similarly, in UK, we saw more than 1 as well. So the concern is there, but the trade-off is that on one end, we can end up getting COVID, which can, in worst case, kill us. On the other end, we can have a vaccine's reaction as well. Although the safeguard is that anybody who has severe allergies, they are asked not to take the vaccine. So they are actually at risk. You are correct on this as well, that the second dose may show more reaction. And this is why it is important that those who reacted to the first dose should not get the second dose, because their reaction will be more. This is the same behavior with other allergens. Our body, when it is exposed to some allergen for the first time, it may not react that badly or may not react at all, but just learn about it. And the next dose, when the mast cells have become primed, the next exposure may actually cause anaphylaxis. So here, the question that is in my mind is still that the reaction to the first dose means that there was priming to something in the vaccine beforehand. So for example, polyethylene glycol. If that is the case, if the person was already primed and then the vaccine kind of triggered the mast cell reaction, then the second reaction would actually be milder or similar as well. But still, to be on the safe side, second dose is not asked. Linda says, ivermectin as a breastfeeding mother of 16 months old child who does not rely solely on breast milk, would you still recommend against ivermectin? So, Linda, I'll give you two answers. One is my answer, my opinion. And again, I cannot ethically and morally, I cannot through internet without having a doctor-patient relationship talk about one specific case. So I cannot talk about your case, but generally there are two answers to ivermectin's role with the for the pregnant women and breastfeeding women. I am very strict about it. I give zero ivermectin to anybody who's pregnant or who is breastfeeding, because the damage that can occur to the brain of the baby is something that would not recover easily. It's not a wound on a skin that would repair. Normally, the nervous system damage can actually last forever. And because of that, I'm just very, very careful. Having said that, I have a couple of studies here. So this is a study that talks about and I have the link in the description, so please do me a favor and read it up. Here they've talked about the drug levels in the baby after ivermectin is given to their mother, but one dose only. So this is not about 2 doses or 3 doses or more. So here what they've done is, if you see here, 4 mothers who had lost their infants at term were given a single 150 microgram per kilogram dose of oral ivermectin. Ivermectin was detected in milk within 1 hour after the dose and for 72 hours after the dose. The average peak milk level was 15 microgram per liter, which is 11 to 20 microgram per liter. So please see they're talking about microgram per liter. And occurred 4 hours after the dose in 2 women, 6 hours in another 12 women. The mean milk level was 9.85 microgram per liter. Using the mean milk level data from this study, an exclusively breastfed infant would receive on average a dose of 1.47 microgram per kilogram. So now compare this 1.47 microgram per kilogram versus a therapeutic dose of 150 to 200 microgram per kilogram. So this is hundreds of times less dose to the baby. So after a maternal dose of 1 microgram. So, but this is one dose. And again, what is not known is that what is the dose that may be dangerous for a baby whose blood-brain barrier is still being developed. So in a hypothetical situation, anyone who is breastfeeding or who is pregnant, I will never administer them ivermectin. I just do not take chances with my patients at all. So that is Linda's. Paul Wolf says, these are the 3 mutations in the spike protein from South Africa via the UK. So if you see here, so this has been a new news that there is more mutations. There were mutations in the South Africa, and possibly those mutations arrived in the UK and then spread there. And I'm still very doubtful about the acceleration of spread. It may be super spreader persons or super spreader events. There still needs to be more data. I'm still not freaked out about this new strain variant. And so I saw some of my friends as well who were quite worried and nervous. But I think it's not going to be that bad, because the changes that I'm seeing are not, at least these changes do not indicate a huge problem with the virus in terms of, has it changed its affinity a lot? Number one, it has changed its affinity, but it still binds to ACE, and the spike protein is still exhibiting the same structure with very minor changes in it. So that spike protein is still open to our immune system and our pre-existing antibodies and so on. So I still have, I'm observing this data more. So if you see here, these are the changes. So here in this diagram, this green one is the ACE2 receptor. And these are the changes. Remember, we talked about N501Y change yesterday. So this light gray part is the receptor binding domain of the spike protein, which has connected with the ACE2. And the virus in South Africa has 3 mutations on it. Now, what does that mean? For example, we know that 501Y increases the affinity to bind, increases the energy to bind. It is also possible that these mutations, maybe there would be some mutation that would reduce the affinity to bind. But so far, that is what is happening. So very, very good. Sorry. So Paul, thank you very much. And then Paul says, the new variant from South Africa apparently includes the mutations you described in the last 2 videos, plus 2 others to the spike protein called K417N and E484K. It looks like it is doing everything it can to improve its binding affinity. Is this where the virus is headed? So Paul, that is correct, that viruses, when they are living in us, they are changing all the time. And this is simply selection pressure, meaning they have to do some things to live better with us, live more with us, and protect themselves more and spread themselves more. So in that process, whenever there would be a mutation that would allow them to bind better or to spread better, that would be selected. That will be more fit than the others. And so it would happen. The question is this virus, when it is entering the cells, how much better the affinity is? Is it, for example, let's say today when people get the viral load, the standard viral load from the exposure, normally within 2 to 3 days, they develop symptoms. 5.1 day is the mean time of development of the symptoms. Will this cause this change in the virus? Will this cause them to become sick the same day or the second day? If that is the case, then we'll say, yes, it is causing the symptoms faster. On the other hand, if it causes, let's say if it arrives in my body today and it just makes me sick right today, I will not go out. And then it will not have a chance to spread. So that is the part that is why I'm still not very much nervous about it. But I'm looking at the data. As you saw, that I had done some back of the napkin kind of math yesterday to see if it is really causing any change in the death rate. Yes, there is an increased case rate. Now that is because of the lockdown lifted, or that is because of the people, shopping for the Christmas or going out more, or that is because of the youngsters meeting and doing more things. Don't know. Or is that really the virus that is accelerated? So we still have to see more. So there is this question, and then I'll come to the live side. Norman Spear says, what caused the nurse to pass out? Was it elevated heart rate? And then Devlin Dog has already answered. My guess, vasovagal syncope. She was nervous being in front of the press. Then, of course, that she was skirmish about the thing as well. So let me just very quickly show you a few links here. And these links are also present in the description of this video. So fainting or syncope after vaccination. So what happens is our heart has vagus nerve. Most of our viscerals have vagus nerve that is connecting to it. That vagus nerve can reduce the heart rate. And normally vagus nerve gets triggered. We used to give in medical colleges, we used to give this example that, let's say somebody dives into cold temperature water, swimming pool, and they were not expecting it to be that cold. So as soon as their body touches the water and it is very cold, they can actually pass out because the vagus nerve would send signals and stop the heart for a very brief moment. And that stoppage of the heart is called vasovagal syncope, because the stoppage of the heart would reduce the blood supply to the brain and the nutrition to the brain, and brain would pass out. Then the person would recover. This happens with sudden surprises as well. This happens with the bad news as well. This happens with good news as well. And this happens with anxiety in case of vaccinations or injections in general. There are people who actually just pass out even before the injection. And then there are people who pass out after the injection. So possibly vasovagal syncope. And now, how do you tell the difference between, is it a vasovagal syncope or is it a reaction to the vaccination? Normally, vasovagal syncope is immediate. So let's say I got the injection. So it's not the injection that did anything. It's just my anxiety about, hey, I'm going to get this vaccine. I do not know what's going to happen. And that anxiety caused the vagal outflow that stopped my heart. That would happen immediately. And then I would pass out and then I would recover. So if you see here in this, there is one more link here. This is some older time from CDC government. Here they've talked about various reasons as well. One is vasovagal syncope. The other one is hyperventilation. So sometimes we ventilate more when we are anxious. So as we ventilate more, we can throw out too much carbon dioxide. Carbon dioxide is actually needed inside the body as well as a buffering system. So if we throw too much carbon dioxide out because of anxiety, then the carbon dioxide washout in our body will cause the breathing to stop for a few seconds or whatever is necessary, and that then we can pass out as well. So there are physiological phenomena that can cause a person to become fainted during the anxiety attack. And this could be pathological as well. So meaning not all syncopes are going to be vasovagal or hyperventilation. There could actually be a reason that the drug has caused some problem. So if you see here, this is WHO's paper, and they're talking about the anaphylaxis versus acute stress response. So anaphylaxis usually occurs after 5 minutes. Anaphylaxis needs a little bit of a time for the allergen to enter the body, to be picked up by the cells, and for the mast cells to degranulate. And during that process, the person would start developing hives and rashes, and then the lips would start swelling up and breathing would start becoming difficult. And if it is, blood pressure would start dropping. And if it is continuing, then the person passes out. It would take many minutes. On the other hand, vasovagal is sudden. So the important thing is lesser than 5 minutes versus 60 minutes, for example. And then what kind of things would happen on the skin of a person who has anaphylactic reaction or anaphylactoid reaction? They may have hives and urticaria or redness, and you can move your finger across the skin and a flare would appear. On the other hand, in case of vasovagal syncope, where the heart has stopped, the skin would actually become cold and clammy and less red because there is not much blood that is coming over there. So I would request you to look at this this thing. So heart rate, for example, is reduced in vasovagal syncope versus increased in anaphylactic tachycardia because the blood pressure starts reducing. So so that is that one, and I'm going to come towards the life side. How is everyone here? I'm going to miss you guys for next 3 days. And thank you very much for super chats. So I'm going to start from the beginning, as much up I can go. So there is a question from Valerie. My functional medicine doctor does not prescribe antibiotics lightly. Due to her concern about damaging intestinal flora and in turn damaging immunity, does ivermectin damage the flora? No. So ivermectin is not an antibiotic. Ivermectin is anti-parasitic. So if there is a parasite, it is going to go and cause its muscles to be paralyzed. So of course, bacteria or viruses do not have muscles, so it does not paralyze them. So no issues with the intestinal flora. Although, of course, your question will then become, well, if it cannot do these things to a bacteria or virus, then how does it help against the COVID? So I have done that mechanism that it helps the cell to shore up their defenses and keep the interferons released and keep the immune system modulated and inflammation lower. So these are the mechanisms by which it works. So not an issue with the intestinal flora. I'm just looking at the questions here. Carolyn says, the virus can be found in urine and feces for 53 days. Is that still correct? If so, the virus is viable or is it merely debris? So Carolyn, I know that it can be found in mostly in the feces for up to 59 days. Urine, I have heard that it can be found in urine as well because it can attack the kidney too. But finding it in the urine is usually when it has actually gone to kidney and has been there. In case of feces, it is actually an easier thing because it is in the throat. and from there it is swallowed and goes into the GIT. It is protected in the stomach. It cannot be killed by the stomach acids. Then it continues on in the GIT and infects the GIT, or just lives there. And that is how it can continue to shed. So if so, is the virus viable or is it merely debris? So for the fecal route, in the beginning, it is supposed to be viable. However, they are saying that when it is shed near the 59th days or those late part, it is not viable or it is not able to contaminate. So is it really not viable at that time, or they haven't seen it to be propagating or causing the fecal oral transmission? That is the question. I think we do not have a clear answer, but I would suspect that when it is present in the GIT, it is living in the epithelial cells and it will not become just debris. Yes, it will be controlled by the immune system as well. So in the beginning, it is active, and then later on, it is possibly not viable. Good question. Arshad says, question, what happens if vaccine is given to an asymptomatic or pre-symptomatic COVID patient? Can it cause harm with more aggressive immune response with COVID cytokine storm? No. So the cytokine storm is a very different situation. Cytokine storm needs this viable virus entering the cells, destroying them, coming out, entering again, destroying them, coming out, going into the immune system cells, replicating and causing the monocytes to reduce, causing the macrophage sizes to reduce, causing the innate arm not to work correctly, and then causing the macrophage activation syndrome when the acquired arm amplifies the innate arm. So vaccine cannot do that. So if I go to this diagram for a second, when the virus is present, virus, what it does is it continues to cycle through this system. So it enters here, then this system becomes activated, then this acquired arm will activate the innate arm, which will activate the acquired arm, and that cycle continues as the virus continues to replicate and come out of the cells and replicate again and enter the cells again and so on. So that does not happen with vaccine. Vaccine is one-time shot. It is picked up by the cells and done. It will not come out. It is not replicating. It is not increasing. It will not come out and go into cells again and then come out and go into cells again. That does not happen. So vaccine will not cause cytokine storm. Or even in the presence of the virus itself, vaccine will not cause cytokine storm. So let's say if I get the virus today and I'm going to develop symptoms 5 days later, and then maybe later on there is more severity, and you have given me vaccine today, vaccine would also take 10 to 15 days to cause my immune system to ramp up. Virus would do the same thing as well. So possibly the vaccine's role is nothing. So 0.5 milliliter of vaccine versus an active virus, which is really growing inside the body, vaccine cannot do anything. Vaccine is nothing compared to what virus would do. So Billy Block says, did you see that on his screen, nanoparticles in vaccine causing allergic reactions? Yes. So the nanoparticles, especially the polyethylene glycol, is what they're thinking is causing the allergic reaction. But please keep in mind that the allergic reaction is occurring in fewer people. Nanoparticles are being injected in lot. And that is what is the definition of allergic reaction, that not everyone responds to them the same way. So there is a comment here. Does everyone here knows the prefix nano means? I get the feeling many don't, and I think it's something awful. Nano simply means very, very tiny, right? Nanoparticle, nanometer in size, very tiny. So Arsha says, any data on how soon do you have 50% antibodies production after the first shot? So There is nothing called 50% antibody production, Arshad. It is the 50% efficacy, especially with the vaccines. Of course, when the antibodies are being produced for the final titer, there would be a 50% time frame at some point. But the first shot creates 50% efficacy in case of, I believe, Pfizer. And they have tested that 2 weeks after the first shot. So just generally, because our immune system, this little messy diagram that I've made, so if I clean it up, this part, the innate part, will respond within 24-48 hours. Then the innate part is going to cause the acquired arm to become activated. This arm can take anywhere from 7 to 14 days to become activated. May that be with the virus or with the vaccine. So if I am given a vaccine today, I can take anywhere from 7 to 14 days to develop antibodies. And that is the time when the antibody production would start. Now, it depends upon how many cells are involved, how much dose of the vaccine is, and then how robust is the antibody response. So we are seeing that after the first dose, the response is not so robust that it can give us better efficacy, so 50% effectiveness. So Steve says it means this. Thank you, Steve. Very good. Carolyn, it's a metric measurement, nanometer, correct. So thank you very much for super chats as well. There are so many questions today. Anthony, here is a question from Simple Garden. Thought on low dose prednisolone. Is low dose 5 milligram as Dr. Patterson? What timeline do you think he meant by long-term and low dose steroids? So again, hypothetically, talking about a patient. So I'm going to talk about my patients. For my patients, what I have seen is, and I've drawn this many times, so there is a difference from Dr. Patterson here. I usually give a pulse for 1 week only to my patients. So what I do is, here is what a low dose therapy for me is. Day 1, 2, 3, 4, 5, 6, 5 milligram morning, 5 milligram lunch, 5 milligram dinner. Same thing here. So 2 days, 15 milligram in total. Then 5 milligram morning and lunch. Steroids should be given towards the morning time and less towards the evening time. So when you're tapering, you just do this. So 5 milligram. My apologies for my handwriting. That is medicine. So then 5 milligram here. This is what I have done for the long haulers, and every single time it has worked. In some cases, more than 1 pulses after some weeks. I believe that when we talk about Dr. Patterson's, his recommendation might be, so I have not heard it, so I cannot exactly say what he means, but it might be 5 to 15 milligram and for maybe longer period of time and then tapering. There are some doctors who do not believe in tapering at the low dose. I don't believe in that. They should always be tapered just as a habit and just as a care. So good question. So we have Vanessa Favor. Tested for antibodies in May, was positive. Tested again in October, was negative. Had COVID antigen Monday morning and negative. COVID antigen, okay, reactive Moderna, received Moderna on Monday. I have had sore arm, flu-like body aches, stomach pains, and fatigue. Today, lung pain on inspiration. Was told that I'm having these experiences because of history of COVID. So I'm just going to try to interpret what they're saying is that because you already had the memory cells available to react to this kind of antigen, presence of the antigen again woke up those sleeping memory cells, B cells and T cells, and they are reacting and they're making antibodies and they're releasing cytokines, which is causing this. It should, I think, go on for a couple of days, at least on the data that they show, and then subside. So Anthony, I know that you have been a long hauler. Have you had steroids given? So you're also getting thymosin. So I'm just looking for the questions. So, Dr. Drake, so generally, of course, the nurse was on TV, and so she became a target for people to talk about her. But generally, speculating about somebody's health, just like I talked about fainting, in general, fainting can happen. But I will not talk specifically for a person. So let's see. Logic question. Do you think ivermectin for prophylaxis works? Yes. So Logic, everyone who I can give ivermectin, I have started them on ivermectin. And so I think it works. From iMask Plus, I think it works as well. And so there are studies as well that I have discussed in the past. And I hope you're doing well, Logic. I saw a couple of comments from you. So Zunar says, question, think the original docking ability of ivermectin will be affected in any way by the new UK variant? No. So ivermectin enters the cell. It does not dock specifically with the virus, although there are some studies that say that ivermectin can actually dock with the receptor binding domain and the ACE2 and kind of create a blockade there. But that is not a major pathway for this. Number one. Number two, I don't think that the mutation in the RBD are sufficient for ivermectin not to work. And ivermectin then has three more mechanisms. One is within the cell, shoring up the defenses, asking the nearby cells not to become defenseless, and then modulating the immune system and inflammatory system. So ivermectin is much more than just the docking part. But very good question. I like it. Shahida has a question. Can it happen that anosmia occurring for something only and not for other things? Shahida, what do you mean by things occurring for? Do you mean that for some people and not for others? I just need a little more clarity. Simple Garden says, thank you, Dr. Bean. We use your steroid protocol 3 times now and had rebound long hauler symptoms. Are at time considered long-term, 2-week plus? Yeah, so then I think that a little longer period of time may be useful. 2-week plus of 5 milligram. Yeah, again, not talking about any one person, but yes, then that may be necessary. Question, do you think ivermectin for Yes, so I think I just answered that one. Logic. So Skyfly says, how useful is ivermectin in treatment of COVID-19 instead of prophylaxis? So I have shared a lots of studies about ivermectin being very, very effective for COVID-19. So if you can please look at some of my previous videos, I have it there as well. Plus there are references in the videos in the description that would actually bring you to the studies as well. Beautiful studies and great outcomes. So Arsha says, what is your criteria to add prednisone in the course of illness or dexamethasone? Is it oximeter versus subjective shortness of breath versus days after positive test? So good question. Of course, oximeter is very, very important. As soon as the person goes below 93, that is a important milestone to quickly start the steroids. I usually look at the number of days as well. I do not prescribe steroids in the early part of the disease because I am just afraid of the virus replicating. Although I see lots of doctors now just mindlessly start with the steroids right in the beginning. And what I see is that their patient, then they recover, they don't become long haulers, they do not become severe, but they have a bumpy ride for 10, 15 days. What I have done is, when I give steroids, I give, number one, I'm looking at the oximeter, and number two, after 3-4 days. And that, so far, I'm seeing that it makes it smooth for the patient to recover. So Frank says, can immunocompromised individuals take the COVID-19 vaccines? Yes. So both Pfizer and Moderna have tested them on immunocompromised. One of my own friends who is immunocompromised today got vaccine as well. So yes. Correct. Carolyn, you're correct. So I actually talked about it as well, that if somebody is shedding active virus in the fecal material, and then they flush the toilet and the aerosolized particles are brought up, they can cause infection. And so public washrooms can be dirty in that way. So the study that I remember is that looked at the patient shedding the virus after 59 days or by 59 days. They had said that they did not see them to be viable. So I am sure that in the early part, they are going to be viable because they're infecting. And then in the later part, it is possible that immune system has kind of started to kill them, and so they're not viable. Just looking at the questions. So there is a question I just saw. Skyfly. Correct in saying that stats of 82% secondary to COVID-19 is a big risk for MI renal failure within 48 hours. Saturations of 82, absolutely. Absolutely. Saturations going below 93 is the cutoff point by all definitions. When it goes down, you have to start getting oxygen. And I have never seen anybody not having organ damage if they are below 80s. So right below 90 should be worrisome, and you should be in the hospital. Or if you can get oxygen, you should have oxygen. So this is a good question. So babes 1, 2, 3, 4, 5. Dr. Bean, how about polyvalent vaccine for COVID strains? Variants. And yes, if there are vaccines, so think about it for a second, that the vaccine that we have today, these vaccines are producing the spike protein, correct? So spike protein has its own 3 parts, plus it has a receptor binding domain, and the vaccines are generating these spike proteins. And we saw that spike protein has hundreds of amino acids in them. That means, and one epitope means an area to which an antibody can connect. 5 to 6 or 6 to 7 amino acids are sufficient to become an epitope. And epitope can be overlapping as well. So that means if there are, let's say, 300 amino acids, we saw that there are much more. Then I'm just doing math here. 300 divided by 6 is 50 antibodies. And this is without any overlap. So imagine that this would produce, of course, polyvalent antibodies. And these would be sufficient for various variants as long as the variant are using the spike protein still. They have not hidden the spike protein and figured out some other way of infecting us. And the other thing is, it is possible that with the mutation, maybe there is one antibody that cannot connect anymore. So monoclonal antibody, which unfortunately is targeted at the site of mutation, may not work. But all the other antibodies that are still directed or are produced against the spike protein are going to be working. So if I get the new variant today, my body would still produce new antibodies against that variant, and it should be able to take care of it. If I was infected before and I have antibodies, I may have a few antibodies that would fail because of the mutation, but I still will have hundreds of antibodies that would be successful against the spike protein. Same is the case for vaccines as well. So the only things that may not work correctly are the monoclonal antibodies if they are targeted to the area of mutation. Or, for example, the RT-PCR test, one of the channels, so there are three channels normally in the RT-PCR test. That means they are looking at various sites on the spike protein, not just one site. So one of the channel can fail that is looking at that specific site. Good question. Okay, so so somebody's saying how much Nigella sativa. So Bernardo, if you can look for one of my videos where I have actually discussed the studies and the dosage for Nigella. So Coolbean 381, how many months after having COVID does antibody test still show positive? How does a person become a carrier? So one, we still do not know if people can become carrier with this virus. I suspect virus can stay in them for a long time, but carrier means that the virus will not do anything to them, but they can shed it. So I think the long haulers technically are not still carrier, they are still the patients of it, because the virus is hurting them or the reaction to the virus is hurting them, and they possibly are shedding as well. Carriers usually are silent. There are some carriers, for example, in other diseases where there can be hurt, but most of the time carriers are host with a amicable relationship to the pathogen, but they can shed. So how many months after having COVID does antibody test still show positive? Antibody antibody tests should show positive for a long time. From the SARS-CoV-1, the antibody stayed on for 2 to 3 years. So ideally, in this case as well, they should stay on for years. So far, 6-month study has been out there which showed that they are positive. Titers will decline. The amount, the volume of the antibodies will decline. That should go up again when the exposure occurs again. Seema question, if all treatments were readily available, which would you use for critically ill patient? Ivermectin, Regeneron antibody, leronlimab, or aviptadil, or steroids, or other? So Seema, it is a very important question, and the answer is not out of this cocktail. The answer depends upon the situation with the patient. If the patient is in viral state, then I would for sure use ivermectin in addition to other things, for example, Regeneron antibodies or convalescent plasma if available, or other monoclonal therapies, or even when I feel that remdesivir is of no use, maybe using that, throwing kitchen sink at the virus, maybe even that. But if the patient has moved to cytokine storm side, then giving them ivermectin still works. Steroids will have to work, and then the aviptadil, for example, as well. But the other antiviral drugs may not be useful. For example, Regeneron. I love Regeneron's behavior. I wish that everybody on the very first symptoms is given Regeneron. We saw that with Trump and with Giuliani, that they got these and they were out in 2 days. We have the solution. So we can look at solution in two ways. Influential people's solutions, which are Regeneron like antibodies, and common people solutions, which are ivermectin, hydroxychloroquine, and zinc. Unfortunately, both of them have not been made available to common people. There are solutions right in our plain sight, and they're not given. That is the tragedy. JTJ, can the messenger RNA vaccines cause Bell's palsy? So we saw Bell's palsy in both cases, Pfizer and Moderna. Now, they still do not agree that their vaccine triggered it, although Pfizer's trial was, excuse me, was halted and then resumed. And they said that this Bell's palsy was as frequent as other general population, but we didn't see the same numbers in the placebo. So if it was as frequent, then the similar number should have occurred on the other side as well. Then they simply said insignificant data because the number is too small. I think that there is something that triggers it. Fortunately, it subsides within a couple of days. Skyfly, hate to dampen the mood, but how are you handling breaking the bad news regarding patients who are likely to pass away from COVID? Any further tips for palliative care advice? So Skyfly, one, I don't work in ICU, so I'm not on daily basis exposed to it. Second, so far in my group, there have been, I believe, 4 or 5 deaths. Majority of them, actually all of them, were not my patients, but were folks who reached out when the patient was in severe condition, or folks who heard from some friend and then connected with me. It is difficult to say that, and I, by nature, for my patients, am always optimistic. I am very careful as well that I don't do anything that would increase the risk, but I'm always very optimistic. But sometimes for example, there are 2 cases where I had to say that the labs are not looking good, and it is difficult. So palliative care is very difficult. I don't know how to, this is a bigger topic than something that I can answer here. It is, for me, it is very difficult. I become, it takes a toll on me every single time. I have not become used to it. And I become sleepless. I know that there are some doctors who, when they look at my behavior, they say it is not very professional that you take so much of an effect. But this has been always with me this way, that I fight a lot for my patient. I fight a lot, but then when something goes wrong, I am very, very sad about it. Arun is talking about the black fungus mucormycosis. Arun, can we talk about it on a different time? Because this is something that can cause respiratory issues. But in the COVID discussion, if we can, maybe we can talk about it separately. Maybe you can tweet at me and we can talk. So good question, Arshad. Is the daily regime for ivermectin, like you do, is more effective and still safe than day 1 and day 3? Do you still do 3 days or 5 days? So when I have a patient who is COVID patient, I do not take a risk and I give them ivermectin. So far, I have not seen any side effect. But you know that I'm very careful not to give it to pregnant women, not to give it to breastfeeding women or smaller children, or somebody who may have a possibility of meningitis. I do not do it. So I give it to healthy people. So far, nothing. So touch wood, I'm blessed and the patients are blessed. But yes, I go on for 3-5 days. AS says, if someone has type 1 diabetes mellitus, is it okay for them to take a weekly ivermectin prophylaxis and the COVID-19 mRNA vaccines? So again, not talking about somebody specific, generally diabetes has nothing to do with the ivermectin. Ivermectin is, it needs liver to be functioning correctly. So if there is a problem with the liver, so again, not necessarily with the diabetes, but if there is a problem with the liver, then one has to be careful. And then COVID-19 messenger RNA vaccines, no worries. The problem with the diabetes is that if it is not controlled correctly, immune system may not be performing well. And so if that is the case, vaccine is still an important thing to do. Nabu says, question, HV6970 deletion in RBD should decrease the affinity of virus to ACE2 receptor. Here's the deal. So let's look at it for a second. Let's say that we have an ACE receptor that looks like, let's say, this way. And we have a vaccine, a spike protein that binds it with this structure. So now imagine that there is a different spike protein that binds it like this, because there has been some deletion here that reduced the internal structural pull, and that allowed this little piece to pop out and connect in this area as well. So now the affinity has increased. So affinities increase is more of a function of the structure of the protein, and then it's binding to the other one, and the bonds that appear between them, and the force of the bonding, than the amino acid's presence or not. So it is possible that you would remove some amino acid, which would open up the structure and make it more avidly spread on the enzyme, for example, ACE2. So Eric the dog says, is California testing sewage for even more COVID variants? I think that they are testing sewage. They are bound to find variants. So when every cell in which the virus goes, when it, so France here, if France is here. So France, thank you very much for sharing that video yesterday. The virologist there was talking about it, that when the cell has the viruses replicating and dividing, they would make, even one cell will make many copies, many types of viruses that would come out. So it is bound to have variants. So Shannon says that I saw YouTube doctor just got vaccinated in 2 weeks post-infection. Isn't it advised to wait 90 days post-infection to get the vaccine? Should diagnosed COVID check for antibodies before vaccine? So Shannon, ideally one should check for the COVID and for the antibodies, and if it is not needed, then vaccine is not needed. 90 days rule is still the same, that if you have the COVID and the antibodies are active and you bring in the vaccine, that might trigger those antibodies to cause a little more side effects. It cannot cause cytokine storm, but the side effects can be more. So I actually think that 2 weeks or 90 days is an arbitrary thing, because think about it this way. When the virus is present in our body, it is dividing and dividing and replicating. It is much more than the vaccine's quantity. And on daily basis, it is increasing, and our immune system is fighting with it. So if during that time or a week later, we give one more tiny drop of the same virus looking thing, which does not even increase in number, then what? But I generally think that somebody who has the immunity does not need to have the vaccine. You're very welcome, Carrie Lynn. Golmuk says, those who oppose ivermectin use always bring up the in vitro study and claim it can't work as it won't reach that dosage level in humans. Can you do a video on this? So definitely. It is correct that the in vitro study had used a higher dose. However, it is now seen with so many studies that the lower dose or therapeutic dose has been working as well. So I can do more discussions, but that is the thing, that so many studies are now showing it to be working. So Machiavelli says, what happens if you get the booster earlier? So here is the thing. Normally if I go back here to this place, Normally, the acquired arm can take from 7 to 14 days to become activated. They are actually waiting for this arm to kind of become a little more active, then give another dose, which would then trigger this arm to become more strong. They are saying, let's say 1 month, because they are being on the safe side to say that we know that 7 to 14 days is when it starts, but in some people it can actually take a month or more for this part of the immune system to become active. That is why they're waiting for 30 days. If somebody, for example, let's say we take a hypothetical case where we take a patient, we give them the vaccine, and then we take antibody test on daily basis. As soon as their antibodies become positive, they can give them the second dose after that, because that would then go and boost the immune system cells that have started working. So because they do not know exactly how soon they would start, they know that by 30 days for sure they have become active. This is why the gap. That means if it was case to case, you could give the first dose, then start testing for the antibodies. And when you have the best antibody titer available, soon after that, you can give the second dose and amplify the results as well. So yes, William, absolutely. Budesonide's steroid function as nebulizer is limited to in the right doses, limited to the respiratory epithelium. So if a person is taking ivermectin, good. And if they can take budesonide at the right time, not right in the beginning, then that is fine as well. So France, I'll do it. Session on the lower dose of ivermectin, that seems to be the big bottleneck. Absolutely. So I'll do one more. I'll pull the data once more together, which uses therapeutic doses. They use lower doses than the doses I use. Correct, Golmuk. So if you serious, okay, so that was not a question. If you give me a second, let me answer some of the questions on this side as well. So here, Denise says some doctors have spoken out about this. What is the question here? COVID-LT says, can ivermectin be effective on any long hauler, or certain characteristics make it more effective? What can cause tingling in the head in long haulers? So multiple questions here. Can ivermectin be effective on any long hauler or certain characteristics? So once again, why is a long hauler is very important. Is it the virus that is still causing issues, or is it the debris of the virus that is poking the immune system, or is it the immune system that has forgotten to relax and calm down? So if it is virus or virus debris, then ivermectin will work, because ivermectin will continue to shore up the defenses and modulate the immune system and inflammatory system. I would prefer always, for short therapies, steroids over ivermectin, because we are going to request ivermectin to do immune modulation or to do anti-inflammatory behavior or function as that, but the steroid do a better job. Where ivermectin can win is that if we are not sure that there is a virus in the cell as well, and we need immune modulation and anti-inflammation and viral protection, then steroid will not protect against virus. They would actually make us weaker against the virus. So then giving ivermectin is useful. So if there is a long hauler who is not sure that there is virus or there is immune system dysregulation, then what they should do is combine the ivermectin with steroids. So what can cause tingling in the head in long haulers? So tingling, there are many reasons. So let me give some of the reasons, and then we'll see what could be for the long haulers. Look, so let's say there is it really depends where the tingling is. Is it on the skin or just a feeling? For example, if we are anxious and we are hyperventilating, we get tingling as well because of the washout of the carbon dioxide. So let's say this is skin, and there is a nerve under the skin, or there is a nerve that is in the skin, correct? If these nerves get triggered, they can produce tingly sensation. And the nerves can be triggered by direct attack on them, or they can be triggered by inflammation around them. So let me use red color here, by inflammation around them. So that can cause nerves to tingle. That is one. Tingling can also be because of the blood supply's irregularity. When the blood supply becomes more or less, that can also cause tingling in that area where it is doing it. That also is itching. Then tingling can also be the sensory area in our brain. That is so let's say this is our brain. The sensory areas in our brain, if they are not doing well, then they can produce fake or phantom tingles as well. And this happens many times when the nerves are compressed, or when the brain tissue is not getting enough nutrition or oxygen, or the pressures are not correct. Then tingling can also occur when there is the lymphatic or the CSF flows that are not correct, or the chemical substances, for example, sodium and chloride and calcium and others, are not correct in the right amounts. So with these, there can be many other reasons for tingling. With these, if we try to connect it to COVID, the most important tingly thing that we have talked about is that when the olfactory nerve and the epithelium around the olfactory nerve becomes infected and the lymphatic flows become impacted, that changes some of the flow of the nutrients within the brain, and that can cause tingly sensation as well. So one way to see if it is related to lymphatics is to do what I had done in a previous video, is to kind of do the massage and the spinal pumps and the cervical pumps, and to see if that helps with the tingling. It can be because of inflammation in the brain or the olfactory area as well. I want you to have a few days. So Corey says, I want you to have a few days off. You do so much for everyone. Thank you very much, Corey. I'm gonna enjoy these days. Thank you. So Leo says, I had said in the tweet that with your permission. So he said, with your permission, you're the boss. So absolutely, the reason for your permission is that I have been with you since March, April timeframe, and we have been doing this journey together. So if I just disappear for 3-4 days, it will not look right. So that is why and we have become used to it. I've become used to it, to interact with you every day and to talk with you every day. And so I didn't want to break that pattern. Input, Varijant says, there are claims that vaccines do not produce IgA antibodies and therefore cannot prevent vaccinated people from spreading the virus to others. Could you comment on that? So let me answer this one. This is actually a good question and something that has been asked many times. So let's look at this thing that, let's say here is a antigen presenting cell, correct? So that may be innate arm cell, for example, a macrophage or a dendritic cell, or that may be our own tissue cell, for example, muscle cell. And it would present the antigen on MHC2 or MHC1. We have done that discussion in the past. Then either a cytotoxic T cell, if it is MHC1, or a naive helper cell, if it is MHC2. So let's just go MHC2 route. MHC2 naive T cell, T helper cell. Then what will happen is, so the question is IgA antibodies. So then we know that T helper 2 will be formed in the presence of interleukin 4 or absence of interleukin 12. That would cause a B cell to become activated, which is called a plasma cell. I always call them pregnant cells because they would start making antibodies and they become big on one side, just like a pregnant woman has a big belly, and then those antibodies are secreted. Correct? So now the mnemonic to remember that what antibodies are secreted is MDGA. So first of all, M and D are secreted or made together. What does that mean? That means that, let's say this is a DNA in the nucleus of this active cell, the B cell. The DNA has the gene to make M antibody and D antibody. I do not know. I think D comes first and then M, but they both are open together. After that, there is a stop sign. Remember, like yesterday, we were looking at a stop codon. So stop sign is really a sign that when these genes are expressing and the RNA is formed to then go and make the proteins, the gene opening would only go up till here, and then it would stop. After that, the G or the IgG part of the gene is present that would help make the IgGs. Then the E part is present, but between them is also a stop sign. And then A is present, and then between E and A is also a stop sign. So now what happens is, when the B cell starts working, it starts making D and M. After some time, what it does is it takes out this stop sign. And this part of the gene, the whole thing is removed. This is gene splicing. The whole part of this gene is removed. So now this B cell loses the capability to make M proteins anymore, and this stop sign is gone. So it is going to start making IgGs. It would continue to make IgD, but it would start making IgG. This is called class switching, that it went from IgM to start secreting IgG. After some time, then some copies of this cell, so let's say there is a copy of this cell, that new copy, the new cell, will not have this part of the gene, and it would have E and A, and it would start making E. And there is still a stop sign, so A is still not made. And let's say then there is another copy of this B cell, and that has removed the E gene, and now it is reached at A and it is going to make A. This phenomena is called class switching. This happens naturally for every antigen. You cannot say that vaccine should not do this versus active virus should do this. So when you give a vaccine, this class switching occurs because of interleukin 4. When you give a vaccine, then, and this part of the system works, interleukin 4 are produced. Remember, T helper 2 cells make interleukin 4 and interleukin 5. This interleukin 5 will cause active B cells to do their class switching. This is independent of the antigen being a vaccine or an active cell. That means we would always make IgG first, then we'll make IgM first, then we'll make IgGs. With that, some cells would start producing IgAs, and some cells would start producing IgEs, and then some would start producing IgAs. So to answer your question, input, we will make IgAs. And so we will have the IgAs present. Now the question which is important is, how much IgA? Will we have enough cell proliferation? Proliferation means copies. Will we have enough B cell copies which have class switched and are producing IgAs? Is that enough to cover our mucous membranes? And when the virus comes in, bind with it and make it disabled, and even if it goes to someone else, it is gone with the IgA stuck to it, and it cannot do much to others. This part of the study, both by Pfizer and Moderna, they said, we do not know. What does it do? So from a technical point of view, it should happen that IgA is produced. From a trial point of view, from the data point of view, they said, we are not sure. So I lost me pods. Dr. Bean, I'm here in UK. As we know, 1 or 2 rare cases of reinfection happened earlier with COVID. I'm very concerned this week. I personally know 2 people that were infected with COVID and have both been reinfected with this new strain. Thoughts? So so many possibilities. One possibility is that the mutation is sufficient to beat previous cells, memory cells, and the antibodies they make. If that is the case, we are in trouble, because then that means a new pandemic all over again. I suspect that is not the case. That is one. A second possibility is that the new virus, when it arrived in their body, it kind of triggered the immune system to start reacting once again. And immune system reacted and tried to curtail it, and they had some symptoms. A third possibility is that if their health status has changed and they have become a little weaker to react to an infection, then maybe that happened. A fourth possibility is that they didn't get COVID the next time. It was a common cold or some other thing that had similar symptoms. So, excuse me, there are many possibilities for this, but if it is a reinfection, which it may be, then we need to understand how many people are getting this reinfection. And we have to make sure that this is not happening commonly. Because if that is what happens, then we have pandemic again. I suspect that it will not be that way. Devlin Dog says, do Rivaroxaban help protect against hypercoagulability in COVID-19? So yes, I have this Rivaroxaban here. It is factor 8 blocker. So it would cause blood thinning or less coagulability. But please remember, this has to be taken in a very serious situation. So it should not, aspirin is fine in general, but don't take these kind of drugs until I think that it has to be in the hospital and under the supervision of a doctor. But yes, to answer your question on a technical basis, yes. A couple of more questions and then I'll come back to the live side. COVID LT says, what percentage of long haulers have myeloid versus lymphoid responses to COVID, and do they have superior TB memory cell immunity, T or B cells? Good question. So let's very quickly look at this in a drawing as well. The macrophages, dendritic cells are myeloid line. Other than there are many other cells that are part of myeloid. There is another part of innate arm cell, which is natural killer cell. It is actually, natural killer cells are so funny. They are actually part of the acquired arm, and they're part of the lymphoid side, but they break ranks with the lymphoid side and say, hey, I want to serve in the innate arm. So natural killer become innate, but they are actually part of adaptive. So they are myeloid. And then on the innate side, we know that we have T helper naives, then we have T helper 2, we have T helper 1, and we have B cells, which becomes active, and then we have cytotoxic T cells. Now the question is, what percentage of long haulers have a myeloid versus lymphoid response to COVID? So what you're saying is it this arm that becomes more prominent in them versus this arm? My observation has been from the studies that the people who have better innate arm response, they usually get away with milder symptoms. And as adults, our innate arm is behaving less accurately for this virus. So most of us adults are actually responding with the acquired arm. And within the acquired arm, there is another observation, and that is, if it is the cytotoxic pathway, then they have less symptoms. If it is a B cell pathway, then they have more symptoms. So the long haulers probably are responding by all these three. My thinking is that they have more B cell response, but excuse me, but it is really not the percentages of this side versus this. It is mostly what is happening with the virus itself, or if the immune system cells, those cells, for example, T helper 17 cell, whose job is to calm down the immune system, or T regulatory cells, whose job is to calm down the immune system, they are not functioning correctly. So, and if it is a macrophage activation syndrome in long haulers, which should not be, but if it is that, then what is happening is they both are amplifying each other. My thinking is, in the long haulers, there is something going on with the immune system amplifying each other, but not like a macrophage activation syndrome, which causes the cytokine storm. And this is why giving the steroids actually suppresses the whole system for a few days. And then when it bounces back, just like restarting like Microsoft Windows, then it is working correctly. Those long haulers who take steroids and then when they bounce back, it happens again, that they get symptoms again, that means they still have viral debris or virus sitting in them, which just restarts. In that case, combining with some sort of antiviral or ivermectin would help. Covet says a simple question: how can I become your patient? I don't practice in the US, so my apologies. I only practice internationally and only for charitable causes. I have actually never taken fee for my practice. Amber, I'm seeing a handful of people warning away from ivermectin as it can cause liver damage. If we are following the I mask plus protocol, is this the risk we should consider? Would taking milk thistle for protocol help minimize? So there is a possibility of hepatotoxicity. So if you see here, this is a single dose. So again, this link is present in the description. This is a single dose of ivermectin, which caused in one person liver toxicity. So it can cause liver toxicity. It is rare though. So the iMask Plus will have to be explained by Dr. Marek. I can invite him once more to talk more about the side effects and possibility of any cytotoxicity for the liver. Whenever I have used ivermectin in active disease for a few days, so far, thank God, thank the lucky stars, touch wood, I have not had anyone had side effects. But it is a good point, and there are cases of hepatotoxicity. So let's go to the live side for a second. Are you missing me on this side? Jem is leaving. Bye, Jem, and see you on Monday. And Jem, thank you very much for your super chat. Thank you very much, Jem. Gold says, no coffee, color me dead. I love coffee. Indrid Cole says, question, I take Plavix to keep 2 stents free from clots. Will that help prevent clots in coronary arteries if I get COVID? Ideally, anticoagulation should protect even in the case of COVID. So yes. But in theory, yes. Billy says, how would you boost the innate immune system? So Billy, I had done a discussion about natural killer cell boosting. So please check that out. And the supplements that I've been talking about, they help boost, or not boost, but modulate the immune system. Denise, this is exactly what it does. The immune system, innate arm versus acquired arm, they start amplifying each other, and now they're playing ping pong, and they forget to stop. The T regulatory cell's function is to stop them, but if the T regulatory cell cannot do that, then they don't stop. Very, very good analogy here. Anthony says, question, long haulers and using low dose naltrexone since June for fatigue calms overactive microglia. Am I more at risk for neuroinvasion if microglia suppressed? Aren't they WBCs of the brain? That is correct. But brain is normally protected by the blood-brain barrier. So most of the time inside, even if the microglia are a little less active, the entry to the brain is not that easy. But I am worried that why, so you have reached this point that you're taking microglia, these drugs as well. We should talk more, maybe, Anthony. So many people have long hauler problem. Perhaps Wood should get back to where virus came from, arrest the culprit, question them, charge them. Yeah. Okay, so let me quickly go over the Twitter as well. There don't seem to be more questions here. Jem, thank you very much. Merry Christmas to you as well, and happy holidays. See you again. Okay, so let's look at this area. Amber says, I'm seeing a handful of people warning away. So that's what we just talked about. Well Habit World says, what is the safer approach for immune system to be protecting me if COVID is mutating? Taking a vaccine or allowing myself to be exposed? Will some protected with extreme reaction with reactions with Dr. Marek's protocol? I hear from an Indian doctor that IVM is working very well. So number one, ivermectin works very well. Number two, no, do not try to expose yourself to the virus directly. Vaccine is still a better choice. And vaccine is going to be 99% effective. If that mutation causes one antibody not to function, then what? So vaccine, vaccine, vaccine. And some people left a message in comment. So I've been talking about vaccines for a few days. So some people have actually said that somehow I'm bought by the big pharma or the vaccine companies, and so I'm their mouthpiece. Not at all. They have not bought me, and they have not given me any money or any influence or any promises or IOUs. There is nothing like that. It is just an attempt to bring information to you. You may have seen that I have never tried to take a side towards anti-vaccine or taking a vaccine. I just keep bringing the data in front of us. So can SSRIs help with the neurological symptoms like tingling and burning? So serotonin inhibitors, selective serotonin inhibitors, they will make your brain a little bit more active. And in that activity, if there is a problem with the brain's, some part of the brain is becoming irritated. I talked about tingling a few minutes ago. Then they can actually enhance that. On the other hand, as you saw from Dallas down there, that instead, if you're taking painkillers type, so the blockers of the pain gateways, the thing is this, I would like to understand why is this happening in a patient more than how to symptomatically keep them away from it. So painkillers or such remedies which are just taking care of the symptom does not take care of the actual problem. We have to look at the actual problem. Do you think there is a correlation between low viral exposure and asymptomatic infection? So Mirror 91. Of course, there is the asymptomatic behavior is for multiple reasons. What we have seen from studies so far, those that have better natural killer, innate arm behavior, like children, they stay asymptomatic. Those patients who respond better with the cytotoxic T cells, they mostly stay asymptomatic. And this area where B cells respond, which seems to be the majority, they have more symptoms and sometimes can become severe. So going back to your question, there's a correlation between low viral exposure and asymptomatic. That is also possible. If the viral load is low and our immune system can just respond to it, just like vaccine, you can think of vaccine as a very tiny viral load. And that helps us to have very tiny response. But immune system gets trained as well. So yes, if there is a low viral load, that would keep us asymptomatic. The problem is, if we compare a tiny amount of virus versus tiny amount of vaccine, and we say, you know what, forget about the vaccine, why not I just get a little load of virus? The problem with the virus is it can actually start becoming, replicating and dividing and just go rampant in our body, and there is no guarantee, while the vaccine will not increase from where it is. So again, that doesn't mean I am a shill to some vaccine company or their mouthpiece or they've given me money. It's just a simple health thing at this time that I do not want anyone to be exposing themselves to COVID. Let's see if we have any more questions on this side. So Steve says, how difficult would it be to develop a test for masses to see if people already have T cell responses to this virus? So the Dr. Bruce Patterson's test, we can either we can create tests that would look at the exact markers for the T cells. They are already available, but not generally available because they're used in research, and they are difficult because you need to cultivate the cells and then culture them and see what is going on. On the other hand, the biomarkers that are released by the virus, by the T cells, can be measured. So if you wanted to see that if the people have T cell, cytotoxic T cell response, we can look at their biomarkers, but if to be 100% sure, we'll have to look at the cell itself, and that is a little bit more involved. I think that given the pandemic, I have been saying this for 4 or 5 months now, that there need to be tests that can look at innate arms behavior, cytotoxic arms behavior, and B cells behavior. And based on that, we should see how to treat a patient and what is the prognosis. So very good question. Barbara Warren, thank you very much for the super chat. So just looking at the questions here. Sapan Singh has a question. Have you considered interviewing Dr. Carvalho from Argentina? Maybe not. So Sapan, can you connect me to him? I would definitely want to reach out to him. Roosbell, thank you very much. Yes, I think Jem left. Somebody was asking if Jem left. Okay. I'm stuck. Question, when will kids get a COVID-19 vaccine? I think the children do not need COVID-19 vaccine at this time. They have not tested it on children. Pfizer says that they have started on 12 and above, and they still are working on it. They still have to come back with the data. Moderna says 18 and above. So we'll see when it happens, but I think children are mostly protected. So John Snyder, thank you very much for the super chat. Biranantube says, I'm long hauler. My doctor gave me a Medrol dose pack. I felt quite a bit better for a few days. However, after I completed, a few days later, I felt worse than I had before. Why is this? So so if I once again hypothetically conjecture that what can happen in some person where giving the steroid actually aggravates it afterwards, that means that there may be virus sitting in that person, and giving the steroid, one, calmed down the immune system at that time, but allowed the virus to replicate a little more. So when the steroid is stopped, the replicated virus poked the immune system a little more. So that means ivermectin adding would help as well, or other antivirals would help. Denise, thank you very much for the super chat. And here is one more question, and then I'm going to go to Twitter once more. Question, what is the significance of smelling someone's gum? What is that? Is wearing a mask? I was also wearing a mask. Does it mean transmission is possible? I didn't catch the question properly. So let me just quickly answer some questions here as well. Karen Cross says, happy holidays. I still don't understand how someone who had the disease needs the vaccine. Are the vaccines antibodies? No, they're not. Different? No, they're not. Will it become like flu vaccination? Then you need to get quarterly. So multiple questions in your question, Karen. So here is the thing. Let's assume for a second that when I got infected, I had actually, let me make the whole virus. So when I became infected, I would produce immune response to a lots of pieces of the virus, the antibodies. they would be against the spike protein and hundreds of them. They will be against the envelope proteins and hundreds of them. They will be against the RNA of the virus, hundreds of the antibodies, and they would be against the N proteins and M proteins and so on. So a person who has the antibodies against the active virus would have thousands of antibodies. On the other hand, a person who would develop antibodies against a spike protein only that is in the vaccine, they would be maybe hundreds, not thousands. But the antibodies that this person is producing against the spike protein are going to be the same antibodies that this person is going to produce who's vaccinated against a spike protein. So that means you're fine. These are the same antibodies. So if you have been infected before and you have recovered and your health status did not change, for example, immunosuppression did not occur, or you're not taking some immunosuppressant or some other such issue which causes the immune system not to function correctly, then taking the second vaccine is really not interesting. I am seeing a lot of people advocating for it that, hey, maybe your antibodies were not generated enough and then you should take the vaccine to have enough antibodies. My answer to that is, dude, they had the infection and they recovered. They beat the infection. They have the antibodies to beat it. If the virus comes in again, they can beat it again. What would vaccine do better than the actual infection? So I do not understand why even medical doctors just continue to say that take the vaccine, and then they continue to find reasons. The only reason to take the vaccine after an active infection is if somebody is immunocompromised and could not make enough antibodies, or somebody afterwards became immunocompromised and their B cells or T cells are destroyed, or they're taking immunosuppressant drugs or steroid for other reasons and they have a lower immune response. So in such cases, taking the vaccine would help them more. But I still, maybe I'm wrong, maybe I just do not get it. I still do not understand that when somebody was infected and has recovered, why is it important for them to take the vaccine? I can give one reason, and that is that if they say, well, we don't want to test everyone for antibodies because people could be asymptomatic as well. So testing everyone for antibody, then giving vaccine is a long process, expensive process, and lots of logistics in it. So better just give it to everyone. I understand that part. Fine. But if somebody knew that they were infected, it was SARS-CoV-2, they had tests done, then they have antibodies, and they know that they had antibodies, then I don't think it is needed. That's how I look at it. AS, thank you very much for the super chat. And I saw Denise, thank you very much for the super chat. Okay, so continuing on with this, this is a very interesting question, and I'm seeing doctors continuing to find ways to say vaccine should be taken. Here is an, excuse me, K-pop super, just give me. K-pop super strong. So he's saying India just had Diwali, but cases and deaths of COVID-19 is decreasing. They had no approved vaccine, but their hospitals use ivermectin. I think we should learn from them. Absolutely. So if you see here, this is the death rate in India declining versus this is the death rate in the US. So yes, good point, K-pop. Dallas for Life says, so there's a question from Robbie Burton. Do the vaccines prevent infection and or transmission, or do they reduce the severity of the symptoms? So technically, infection simply mean virus arriving in our body. So vaccines don't do that. They reduce the severity of the symptoms. In some people, they don't get the infection, meaning they don't get the symptoms. So reduce the severity of the symptom or avoid the symptoms altogether. The important thing is they reduce or almost block somebody becoming severe enough that they die. That is what they have proved. So the other part, transmission, I discussed it. ideally transmission should reduce as well, but they say technically from a concept point of view it should, but they say we do not know. So good question. Luke Henry says, do you think that Johnson & Johnson vaccine will be more effective than the Oxford vaccine? Aren't they basically the same type of vaccines? Yes. So your question is correct. Your conclusion is correct. They both are adenovirus vaccines. They may be tiny bit different depending upon what part of mRNA they exactly took from the virus, how much of the spike protein they have taken, and some nearby part of the genes as well or not. So there may be some difference, which would produce some difference in their antibody production, but generally they should be similarly effective. Tanzo Kang says, please continue with your amazing work. Never get discouraged by delivering knowledge and promoting discussions. You bring hope in our lives. I am a hypochondriac. I only survived this pandemic so far because of you. Thank you. Thank you, Tanzo, and thank you for being with me during this time. I totally enjoyed it. Luke Henry, please remember to buy DrBeen a cup of coffee for Christmas. It is the least we can do. He puts on a ton of work into the lectures to help us. Thank you very much, Luke. Paul Elkin says, these allergic reactions to the Pfizer vaccine seem to be occurring in clusters, 3 in Alaska and batch in the UK. Do you think this could be due to cold chain errors in specific shipments? One vial has 6 doses or 5 doses. So if more than one vials have gone bad and the reaction is to a spoiled vaccine, then lots of people would have that reaction. To me, it still seems like an allergic reaction more than bad vaccine reaction, because it's not just one vial and part of a vial that would go bad. If something has gone bad, then the whole batch is going to go bad, and that would cause issue for lots of people. Tanzo Kang says, and last one here, any info on the efficacy of the AstraZeneca vaccine? Seems UK is going to approve it early next week, but seems like it is taking a long time for authorities to review it. So, Tanzo, I think you remember I had done this discussion about AstraZeneca vaccine is 62% effective and 90% effective and 70% effective. So they talk about the dose and half dose and the full dose. So we are still not clear what is happening with them. So maybe more data is necessary to look at. So that is why I think we should be more careful with AstraZeneca. And I had done the discussion about their data as well. There is another video about AstraZeneca where I talked about the efficacy. So this is what we have on the Twitter side. Now back here to the live side. So my throat gets dry and I get that cough. I had cough for a long time, but it has recovered a lot. So Christine says, how to trust any vaccine manufacturers who have had many court judgments against them for very serious infractions costing many lives. Yes, so the only way I can trust them at this time is the trial results. So that is all I have to go on, regardless of their previous track record. Absolutely. So Anthony, I go every morning to Starbucks. So that is the only thing I do every day in the lockdown, that I go for my Starbucks Pike Place. I love Pike Place, no cream, no sugar, and I take it every morning. William Goff. So Anjan says, I would be very, so what is the question? Let's see. So I'm going to continue to go up to look for the question. AS, meanwhile, when taking 0.5 milligram melatonin, my resting heart rate is elevated about 5 beats. And I also sleep less than without melatonin. Can you explain why? So yes, so reduce the dose. So in some people, melatonin dose is not uniform. So if it gives you this kind of a thing or vivid dreams, reduce the dose, and then see where does it become more suitable for you. So I'm trying to see William's question. Charles Kimani, Regeneron, Chemostat, Mesylate, and the vaccine. Good combo. Regeneron is very, very strong. So if becoming severe, Regeneron, I think that Regeneron should be even in the early cases, outpatient. So yes. Shahida's question, antibody hundreds in number or in types or both? So of course, Shahida, what would happen is first antibodies will be formed hundreds in number of IgM type. Then the class switching would occur and they would become IgG, but of all those binding types. Then some IgE, some IgA, and IgD would continue to be formed. So both. Thank you very much, Aaron. Merry Christmas to you as well. Okay, got it. Billy Blog kind of helped me understand the question. Apologies, sometimes I become too focused. Her question was, if she can smell gums through 2 layers of mask, surely virus particles would also be transferred. No. So first answer, no. A little more technical answer, depends upon the material. The smell that you feel are very tiny particles, smaller than the virus as well. The various type of material can control a specific size of the virus, because not only they can block the virus from crossing between them, but they also have electrical charges to kind of attract the virus and capture it. So virus may be small to pass through the hole, but the electrical activity, for example, on surgical masks, can capture them too. So having the breath smell is not the same as if it is coming in with all the pathogens on it as well. Thank you, Denise. So I think this is the question, William. Does lysine have any benefit in combating COVID? Lysine alone. So William, I'll have to look at some studies to see if lysine alone has any benefit, and then talk about it. Off the top of my head, I do not understand how this mechanism would help. So my homework to do. Arun says, SOS, my grandmother got rebirth after tocilizumab and methyl, but now she is diabetic. Is it reversible? What is rebirth? And Arun, once again, specific patient, can we talk separately? When somebody gets the steroids, they can become diabetic for some time. Steroids are sort of a stress hormone. And our body's reaction to stress is, so let's say if I become stressed out today, we have all been stressed out for the whole year. What happens in stress is that we release hormones that are for stress, that includes steroids as well. And the result, our body has a very funny response to that. And what body does is it asks the tissues not to use glucose and save it to stay in the blood, so that when the person is going to start running, because our body only thinks that we are stressed if we have a lion chasing us. So what are we going to do if something is chasing us? We're going to run. So body tries to keep sugar available for the muscles to use. And that is the same that happens when we give steroids. Steroids give the body the same signal that we are under stress. And the result is body stops using or reduces using glucose other than in the muscles, and that appears as the high glucose. So once the steroids are tapered off, normally the glucose levels go down. Zonar says, any updates or studies showing the virus may be able to hide out in privileged sites? Most of the studies I've seen so far, they say that in post-mortem, we have seen virus hiding out in these places. And the problem is that if somebody had died of COVID, they already have virus everywhere and their blood vessels are dilated because they have cytokine storm and they have interleukins being generated. And when the blood vessels are dilated, lots of things are going to enter the blood vessels and get out, including the virus. Then the dilated blood vessels would allow the virus to go to all those tissues where it should not. So these seem to me as exceptional states. And then in normal patients who recover well, normally it should not go and hide in the immune privileged sites because we don't allow these things to go there. I'll do some more studies, but this is what I see so far. So Jeev says, does a virus being able to spread quickly equated to being less lethal? Like in Ebola, patients are so sick they are unable to travel and therefore spread the disease. That is correct. So that is what I've been talking about for some days. This virus has one advantage, that it could spread fast and still be more lethal or equally lethal. That is because of this silence window. So if I get the virus today, I might take 3-4 days for it to show symptoms. And during that time, I might unknowingly give it to others. So if that continues to happen, then the virus can stay same way lethal and spread as well while the spread is accelerated. So So Arshad, no, I do not take ACE inhibitors. Most of the time it is the cats, the dander, and then today right on my head, the heater was going on as well, and the hot air does this too. I think I have allergies as well. So it is much better. A few months ago, it was very bad. Oh, got it, William. So, got it. So, I would do some more research and talk about this mechanism. So, I understand what you're saying now. Cool. So, I think this is what we have for today. Thank you very much for my 3-4 days off. I would see you on Monday. I would have a lot of fun in the next 2-3 days and lots of coffees as well. Please stay safe. Please stay protected. Happy holidays. Merry Christmas. Enjoy, relax. Please be careful to protect you. It is not bad to try to be to protect yourself and others. It is totally civil and it is important. So thank you very much. If you like, please like, subscribe, and share this. There is a link in the description for buying me coffees, and there is a link for donations as well, whichever you like. So once again, Merry Christmas, and I would see you on Monday. Bye-bye.